I want to welcome you all to the Grand Rounds for Vein and Lymphatic University. Have a special guest, Dr. Mark Whiteley from the Whiteley Clinic, who is a very well recognized, very well published, and very well thought out investigator who's really had a long history of looking at venous disease worldwide. So take it away, Dr. Whiteley.
Thank you very much, Neil. Thank you very much. And thank you also to Victor and Lowell for inviting me. So I'm going to talk about the stenting in NIVL cases and May Thurner, as some people like to call it. My concern at the moment of the increasing numbers of patients we're seeing who are being offered stenting or even have had it in cases that may not or probably do not need it. And I'm going to illustrate this with one case today. Here's my disclosure slide. So the case I'm going to present is she's a 31-year-old biological female, came for a second opinion to me because she had a strong family history of varicose veins and she started noticing veins appearing on the right leg in 2017. By 2023, she started to notice some discoloration coming and she's had early C4 changes. However, there's no ankle swelling, no pelvic symptoms, certainly no flank pain on the left side, no a history of any hematuria, microscopic or macroscopic, no venous claudication. She had previously gone to a colleague in London and told him she'd not had any previous thrombosis anywhere, so no DVT in the past or even SVT, but no DVT, and she hadn't had any venous treatment, so completely virgin venous network. So the doctor suggested that because she had deterioration of the skin at the right ankle, she advised that she should have an MRV to exclude an outflow obstruction, which it's sort of, it's something that could be considered, but certainly wouldn't be the first call for most venous surgeons in the world, I would suggest. This is the report from the venogram, bits taken out of it. So prominence of the parauterine veins, a degree of prominence of subcutaneous pubic veins, but only a degree. Significant nutcracker on the left side, a 9 millimeter ovarian vein at the pelvic brim. On the right side, ovarian vein 5 millimeters, minor indentation of the right common neck artery, but sorry, the right common iliac vein. But on the left-hand side, significant May-Thurner compression of the left common iliac vein by the right common iliac artery. Also, because she's lying flat, common femoral artery collapsed. And the conclusion was the significant May-Thurner compression of the left common iliac vein. Also, they noted a significant anatomical nutcracker. Now, again, remember this is on MRV supine. So the previous surgeon told her that she should have a stent of the May-Thurner lesion, as this is shown up on the ultrasound. But I was concerned because the May-Thurner was reported obviously on the left and her symptoms and signs were on the right. So this is one of those sort of cases where it's sort of reading something off a report and not putting it together with what the patient's actually come to see you with as a problem. So when I assessed her, she's exercises regularly, absolutely has no problems whatsoever with exercising. She's very slim. She obviously had varicose veins on the right-hand side, particularly a couple of little ones on the left. She had very early C4 changes, but absolutely no edema on either ankle or swelling. Unfortunately, she wouldn't give consent to me showing her photographs, which is a shame. But these are the duplex ultrasound scans. So the way that we do it in our clinic is we color code the scans. We have blue, which is normal antegrade flow, and you can see her deep veins completely normal, no thrombosis, no scar tissue, and we do look specifically for those. She's got reflux in the GSV, reflux in the SSV, AASV, and she's got three incompetent perforators. So certainly enough here for some varicose veins and early skin changes. Left-hand side, interestingly, smaller veins, but still some reflux that can be elicited. So that would go along with her sort of family history of more progressive on the right, but reflux coming on the left as well. Uh, I think just to point it out at this point here is if we'd seen this, we probably wouldn't have even thought about doing anything in the pelvis because this seems like a fairly simple case of leg varicose veins in a slim lady. And the only hint as to why we'd even think is there's a small but relatively insignificant contribution of pelvic venous reflux coming in the paravulvar region. So, because she had had this MRI done before, we did the usual Holzlock-Harrison protocol, which is 45 degrees transvaginal and then external in a prepared bowel with the patient in all different sorts of positions, sitting upright, head down, and over to the side. And this was the impression reflux in all four pelvic territories, as we call it. So, both left and right ovarian vein, although more significant in the left and reflux in both the internal iliac vein areas. And there did appear to be a narrowing in the Thurner area. So here, where the right sided artery passes over the left-sided common iliac vein, and also but what looks like the narrowing at the renal angle up here for the SMA and potential nutcracker phenomena. Now, I am a great believer. I'm not a particular great believer in cross-sectional imaging. I'm more of a believer as in slim people in duplex, but I'm a great believer in listening to the patient, but also single cuff air plethysmography. And I do want to point out, because I've had several people talk about this before, about double cuff. I don't believe double cuff, where the patient lies still, but single cuff air plethysmography by the Kaladiki and Latimer technique done, and this was actually done by Chris Latimer, so a very experienced guy. And what you do is you put a cuff around the patient's calf, let it fill up, and then you lie the patient down and put their leg up. When they did the original work, they actually they did it in Germany, and they had a table that they could strap the patient to and tip them upside down, which unfortunately we don't have in England, and I'm not sure English patients would allow us to do that. So we have to do it by just basic patients lying down themselves and lifting their leg up. But she had waterfall outflow on both legs. This was the report here. So she had the last bit's the important thing. So she didn't have a huge amount of reflux on either side, it must be said. It was a cold day, but absolutely no evidence of any outflow obstruction at all functionally using single cuff plethysmography and gravity. So my advice was contrary to the previous doctors. I said there's no clinical evidence of any pelvic outflow obstruction, no DVT, swelling, venous claudication. And I think most importantly, not even any edema. The C4 skin changes were on the right-hand side, which is the wrong side of the discovered May-Thurner syndrome. Obviously, nutcracker, it may be that the left side is left ovarian vein is an escape for that at the moment, but she's certainly not got any symptoms of that and never shown any. The duplex shows she's got a very good reason for her C4 with just superficial vein reflux. So, I'd put that down to myself as I wouldn't even think of pelvic veins unless I'd treated her leg veins and she got worse. And we have to remember, as has been presented by Peter Glowinski, when you have a stent and you put it into a vein that can be normal, you've got a lifelong risk of intimal hyperplasia and a risk of stent migration. So my advice was endovenous laser ablation, close the perforators with trollop, with or without phlebectomies, and then foam sclerotherapy. We do that 8 weeks later and review her later. And as I've often quoted before, my view is that you really need to earn your stent. You should never reach for the stent as your first line treatment. You have to really because of the long-term consequences of a stent, you really have to make sure that that's exactly the right thing. And in a case like this, I don't think there's any indication for a stent at all. But if I think that if you're sitting on the sides and you're not quite sure which one round, I'd always embolize and see if that made them worse before stenting. And I hope that's controversial enough to get some questions.
We should, thank you. We have some invited discussants here. We'll start with Dr. Sadek.
Sure. Thank you to Professor Whiteley and Hingorani for this cogent discussion on such an important topic. And I think we're all wrestling with this and trying to figure out the best way to incorporate stenting in an appropriate manner. We had appropriate use criteria that came out for superficial venous insufficiency through the American Venous Forum, and I think it's probably likely that similar guidelines or criteria will need to follow suit eventually for stenting and other interventions. Again, I want to agree because we simply must get this right. Patients can be, and the thing is, there are patients who can be quite debilitated from a NIVL lesion as well. And they can also exhibit demonstrable relief following stenting. Conversely, as Professor Whiteley stated, if you overtreat, that's a true concern. It may not help, and it may lead to harm in the long run for the reasons stated already, including the risk of contralateral thrombosis with a lot of previously high placed stents. When you do evaluate series, though, patients can still improve. So I just want to keep that in mind. Especially Raju Neglin has put out a number of series that have shown clinically and statistically significant improvements in VCSS, quality of life, and even an increased rate in ulcer healing. A different patient, obviously, than the one that's presented today. I think also in the United States, and even anecdotally, it does seem that folks are getting the message. Population data and probably suggests NIVL lesions are being treated a little bit less commonly, or at least the treatments are plateauing a bit. So maybe there's a correction, probably due to this recognition and just an increased knowledge base. I just wanted to ask some additional questions. I like that you said, and I've heard you say that previously at talks, that you have to earn your stent. What else does that mean to you, Professor Whiteley? I mean, in my mind, you have to at least start with a very severe presentation if you're going to be dealing with non-thrombotic iliac vein lesions. Maybe other surrogate markers of deep vein reflux. Maybe you've already treated every superficial vein and they are still progressing, as you said, or perhaps they've had recurrences. What does that look like to you that a patient has to earn their stent in addition to the case that you mentioned? Thank you again.
Yeah, thank you very much. That was very eloquent. Thank you, Dr. Sadek. And I think you're absolutely right. I agree with you. I didn't want to come across as a sort of evangelist where nobody gets stents, because we've had some amazing successes with stents. David Beckett, who's our interventional radiologist, has opened up some totally occluded iliacs and GSVs with the push and pull techniques, which frightens the wit out of me, even as a surgeon, I can tell you. And I've seen some amazing stuff with Brooke Spencer on your side of the pond, who just amazing work. So I think, like with all of these things, I think we start at two ends of the stream, don't we? We've got one end, like this lady, which I think is clearly an incidental finding, and like Bill Marston's recent paper, you can, on cross-sectional imaging, you can find totally irrelevant. You can find totally irrelevant images, which when you do functional tests are not there. Then you go to the other extreme where you've got debilitating stenoses or occlusions, where stenting is absolutely life-saving. And one of the things that I'm always fascinated by, there's two things to say, really. Obviously, there's what we could talk about is the patients, at what stage is that cutoff? But there's also the other thing, and I think when I go to international meetings, one of the things that's become really interesting to me is when we all have different populations. And I think it's very interesting to know that we've got the different populations. And some of us work in areas where we have, relatively fit and healthy patients, and others live in towns where there's been more maybe drug abuse or most post-thrombotic syndrome. And, we all stand up and we say, in my experience. And I think sometimes we have to also remember that we have different populations and different outcomes expected of us. And so we always have to be a little less assertive than I might have been 20 years ago when I was younger and less experienced. And so there's always those two things. I think we can talk about generally which patients, and we all have in our minds which patients we think we have to have, but then we also have to put that into context with the population. So as a sort of general rule of thumb, I think we'd all agree on somebody who had swelling of the legs, C5, C4, probably down to C3, with a clear stenosis and not much in the way of reflux. And at the other end of the scale, they would be stenting, obviously. And the other end of the scale are the people who are clearly varicose veins with absolutely, no sign of any indentation at all. Where it becomes interesting is that middle ground where we've got the patients who have got some pelvic varicosities, and the argument, and then symptoms, and maybe a bit of edema. We haven't progressed to a DVT, which would make us really want to do it. But we're at that stage, and there's the argument, I think, at the moment is centering in my mind on why the varicosities are there. Because we're seeing a lot of another area of interest of mine at the moment is saving women who are being told they have to have hysterectomies for chronic pelvic pain, who with some coils and foam are suddenly pain-free because those varicosities are clearly reflux only. But then there are those varicosities that appear because of an obstruction. And we don't, that's the sort of argument at the moment is why have you got those pelvic varicosities? Because one, obviously, you can close with, your foam and coil or plug, whatever you wish to use, or glue. And the other one, you have to relieve the outflow obstruction. I think we're not actually there with a gold standard test to be able to answer that at the moment. And that's, to me, I think that's one of the most interesting cases, especially, of course, in our males and our women we can't do transvaginal scans on. And it's, those are really difficult patients for us at the moment.
Great, thank you. Dr. Abramowitz, did you have some questions also to ask from Professor Whiteley?
Yeah, I think it's really refreshing to hear that the tide has turned in terms of how we're characterizing NIVL and what I tell patients in terms of their expected response. We do see a lot of stenting for swelling in the United States, particularly since the reimbursement changes that were made a few years ago. And patients just don't do well. And the data tells us those patients don't see resolution of their swelling, and then they have the potential complications of the stent that's being implanted. When thinking about NIVL stenting, beyond swelling and hemosiderotic changes or things that would be markers of C4, C5, C6 disease, do any changes in the vein itself based on intravascular ultrasound or suggestion that it's not just a NIVL compression, but there's evidence of phlebitis, webbing, synechia at the area of the matrix compression change your algorithm or your treatment philosophy?
Thank you. That really is an excellent question. Because my basic premise is that I think IVUS is overused and expensive because I don't particularly like the fact that it's at the end of the day, it's still a cross-sectional imaging. However, having said that, I have to qualify that it was when you do find, these very fine valve webs and things that you wouldn't find any other way, it becomes absolutely essential. So there are cases where you think, goodness, thank goodness I did do an IVUS. And so I think for me, it comes down to function. So we're very lucky we have Chris Latimer, and so we do the single cuff air plethysmography, and I'm a great believer in that because if that shows an outflow obstruction, you do everything to find it. If you haven't got an outflow obstruction, and the question is, is it just you haven't provoked it enough? But my sort of cutoff is I really want to see a functional test that says there's an outflow obstruction. And then once I've got that, then yes, absolutely. Then you look for the reason you've got it. So I wouldn't do it just on an appearance, even on an IVUS, unless it was causing a functional problem. Now that functional problem, hopefully I'd show up in a test, but if the patient's clearly it keeps on blowing perforators, for instance, or, it's sort of got edema and the symptoms, they're just not really in keeping with any other cause, then, I'd be much more keen on doing an IVUS. And if I saw something, then taking it seriously. But again, I wouldn't treat an IVUS image unless there was a either clinical reason or functional test reason. The one thing I would say, I'd like to say, and I've never seen a paper on this, and somebody might be able to tell me that it's been there, because obviously trying to keep up with the whole venous literature is impossible these days. There's so many things. But I don't know if anyone's ever done a very good functional IVUS where people put it into an IVUS into a stenosis and then they either put a surge of blood through with a cuff or even tip the patient. I haven't seen that. That would be to me a much more logical way of using the test.
Yeah, so this is maybe I can comment on this. This is a good point, Mark. The functional assessment. So the problem with IVUS analysis is still that you are doing it in a supine position. That's a problem, yeah. And it's the same with MRV or CTV. Patients are sent to MRV, CTV.
they got told, oh man, you have a 90 plus percentage stenosis there, you need a stent. Yeah. So they come to our outpatient clinic and say, I have a 90% stenosis. So the question now is, what is the right functional assessment? IVUS is a good thing, Steve. I completely agree. If you see web spurs, it could be a clear sign that there is a significant Thurner. But the symptoms must be clear, and you pointed out well, Mark. Superficial things is not an indication for me. Even C3 is not an indication unless the patient has a PTS and a NIVL, then it's a different story. But the symptoms are important. But the question is, what are good functional tests? So what I typically do is I do a supine duplex ultrasound, Doppler ultrasound, and then let the patient stand up and do the same in a standing position. And sometimes you can see, wow, 90% compression. Now it's less than 50% compression. And then I say it's not a fixed Thurner. And if the patient has not the classical typical symptoms, then I would never ever go for stenting.
Totally agree. And we're just about to publish a series we've done where the vascular technologists. I don't do my own ultrasound. I have to put my hands up. I'm not good enough. But we have some very good vascular technologists, and they've been doing different maneuvers with patients with narrowed segments in the Thurner area. So it's sort of a left common iliac. And you're absolutely right. I mean, what we should be seeing if we're going to be considering stenting is a fixed stenosis, and if that stenosis in different positions gets bigger, then we have to be very suspicious of doing a stent.
I think others have also looked at hydration status, time of day, and also some of the compliance of the vein itself. We've been looking at some of the lesions seem to be fixed, but they seem to be much more pronounced during systole when the artery is obviously pressurized. But that suggests that there may be some interplay between the vein wall itself, a very stiff vein wall or not, and what's going on inside the artery. So are these not necessarily fixed lesions, dynamic lesions? And not all of us have Dr. Christopher Latimer available, or APG for that matter. You have some of the world's best APG people in your lab and a pioneer. How do we go forward to identify those patients that are going to benefit? Because we all have seen those patients, and they're not all C6 patients.
Yeah.
And those patients who we can probably just watch and treat their infrarenal great saphenous accessory small saphenous vein reflux alone.
Yeah, I mean, I think that's the thing. I'm very fortunate because what I do is when I identify a problem, I go. And Chris doesn't actually work in our lab. I have to beg him to come each time, and we have to go to it. So I have him come on occasion. I'm not sure if he'll fly all the way to States. I'm sure he would if you asked him nicely. But it's full time. You're right. We are actually working. We've got a research project at the moment, and I've got we've got some patents out on a new device that is going to be more user friendly and it's going to give us similar sort of information. So, and we'll be going into clinical studies soon. So, the whole of my life is based on trying to work out the function. Short of that, I think it does come down to using the best equipment you've got currently and clinical common sense. And I think that's the way down. And I mean, what you said about the hydration and the vein wall is phenomenally interesting because I mean, there's that paper from Russia a few years ago that showed that your amount of reflux changes from morning to afternoon in the saphenous, and that's down to they call it orthostatic, but we also know you wake up dehydrated and you drink during the day, so it might not just be orthostatic changes. So we don't fully understand vein physiology. I think when it comes down to it, we're still in a position where there are clear indications you need a stent, to PTS, with the thrombosis, etc. There's clear indications where you should run a mile from it. I think when we're in the middle, I think that medical legally, you should probably consent the patient along the lines of an embolization is going to occlude a vein and it's permanent and leads to very little long-term problems. A stent is for life, and it means a lifetime of worry and checking it's open and anticoagulation. And therefore, if you're really in the middle of the two, embolize them, but tell them, if I worsen you, it will be a stent, but then we really know you need it. And hence you have to earn your stent. And that at the moment is the only advice I could give you. I don't think I could give an algorithm, because we all know about the 8 stone lady versus the 35 stone lady. There isn't going to be one algorithm that's simple. So I think, without sort of going into some massive sort of discussion about if and but and everything else, I think it really comes down to that if you're in that situation where you truly can't sort out one from the other, then embolize first, but with a good consenting and explanation to the patient that the salvage will be the stent.
So another question that is a little bit controversial is your patient, let's say she had a severe right common iliac lesion. Should we be stenting patients who are so young, even if they have clear-cut indications? My concern, and you touched a little bit upon this, is we don't really have literature for 20-year patency rates for iliac vein stents, for thrombotic or NIVL patients for that matter. Should we be putting in stents for where we really don't know what the outcomes are? We think they might be okay based upon some of the large published data sets from 5 and 10 years follow-up, but we don't have in your patient what she may need 30 years or 40-year data. Should we be putting in stents? Should there be an age limit, or is there a real imbalance between the patient's symptoms, their physiology, and what you've already done?
You're absolutely right. And as every doctor in every country knows, do no harm. And the trouble is what you don't have of that knowledge at the moment is, when you do your risk benefit analysis, you know the natural history of not doing it, but what we don't know is the risk analysis of doing it. And we're all so happy with ablation nowadays, and occlusions and embolization, because we've got a good data there, and also good histological data, so we know what we're doing. But you're absolutely right. I think you don't have to go to many meetings before you realize people say stents at the moment haven't been optimized for veins. The Glavinsky's case really shocked me when I saw him presented in France, when he had to, in Paris a few years ago, when he had to remove a stent, and the intimal hyperplasia was in there at all. And I'm terrified of stenting 25-year-olds, 30-year-olds, 35-year-olds, unless I'm absolutely convinced that I'm changing their life enough to make it worthwhile any of those sort of risks, because it may well be in the future there'll be an industry in having to do bypasses if you can't recall these out. Is a big worry. Whether you're going to be able to re-stent through intimal hyperplasia. Presumably you will be able to, but you're taking something that might be only a small quality of life improvement for something that's going to become a major intervention later on. So yeah, I totally agree with you. I think we don't have an answer to that question at the moment.
There's also a question that hits upon when would you consider stenting? Would you only consider it for post-thrombotic patients and leave it off for NIVL patients? But I think the literature has shown that some NIVL patients may benefit. So if you have a patient, let's say a C6 patient or a C5 patient with reflux in the infrarenal veins and a tight lesion on the common iliac vein on the ipsilateral side, and cross-sectional imaging suggests that this may be severe. Which one do you fix? Do you fix them at the same time? Do you fix them sequentially? Do you do the infrarenal reflux first? We don't really have good data, and everyone seems to have an opinion on this.
I would always do the reflux first. So I do the infrainguinal reflux first, because you've got to take away that as a cause of their symptoms. And let's face it, if they get completely better after that, you've got to get out of jail free card. So I'd always do the simple things that are going to work first, provided it's not going to be putting them at risk of any deterioration, which I don't think it would be in that case. So I'd always do the varicose veins first, let them settle down, progress them, see them at 1 month, see them at 6 months, and then if they still had problems, then consider doing the outflow.
I want to thank Professor Whiteley and the discussants for their excellent, robust discussion on these topics that are quite controversial. You touched upon a lot of different topics and helped clarify some of the areas where we're at and hopefully where we need to go to. Next week, we'll be talking about sclerosae on New York City time, June 3rd at noontime. So please do attend, and I look forward to these robust discussions and controversial topics. Thank you so much.
Thank you very much.
Thank you.
You.